We're gonna get started because that'll get everyone back in. Now the next panel, and I'm Mark Goldstein from UCSF Health Hub. One of the big things that we do at Health Hub is we basically work with early stage companies and we help them find great investors, mentors, or help them with getting clinical trials. So what we're doing right now is we're going to feature 3 amazing early stage companies. And these are 3 truly great companies, all focused in mental health. And this isn't so much of this isn't like a pitch contest that you'll typically see. We're not at Shark Tank. That's not what this is about. This is about basically the companies taking 5 minutes talking about why their product is so great and why it's so important. Sure, if you're an investor, they'd love to talk with you too. But they're basically talking about why their product is really making a difference. So I think we're going first. I think, Rebecca, you get to go first because you're the one who got off the plane. Where are you? Right here. Up, come on up. So Rebecca runs Lucid Care, which is virtual reality for drug and alcohol abuse. And it's really, think of it as an alternative to a traditional program, like an AA or an opiate center. And really, she has a great solution, really, that puts patients in a really safe state of mind. And it's an alternative to a Reva or other, a script that someone might take, but it's very consistent from what we just heard on the last panel. So, Rebecca, take it away.
Thanks, Mark. I appreciate it. Hi, everyone. I'm Rebecca. As Mark said, co-founder and CEO of Lucid Care. When I was 15 years old, I was here at Children's Hospital of Philadelphia. This is where I was diagnosed with a brain tumor. When I awoke post-surgery, I was a completely different person. I discovered that I had a new personality, had mild cognitive impairment, and epilepsy. My neurosurgeon even told me that there may be a chance that I won't go to college. So, understandably, I developed anxiety, and I was given antidepressants to help me navigate through my new reality. But the symptoms were so bad that I had to stop altogether. And instead, I became committed to helping myself and accelerating my behavioral change through meditation and a lot of resolve. So a few years ago, I started working at Samsung, and that's where I discovered virtual reality. And when I discovered virtual reality, I understood that this was the missing link that I wish I had to help accelerate my own recovery. So once I understood that, I left Samsung and became a VR consultant at Stanford Children's Hospital. And there, I helped co-develop the first VR study to reduce anxiety for kids right before their heart procedures. And I took those learnings to start my startup, Lucid Care. My co-founder and myself decided to focus on the drug and alcohol epidemic because we understood that these patients also suffer from severe anxiety and are dealing with cognitive impairment themselves. 1 in 10 Americans suffer from a substance use disorder. So we knew that we could use VR to make a fundamental impact on their lives. According to NIDA, 90% of patients that are abusing alcohol will relapse. 60% of patients abusing drugs will relapse. This is a crisis that is on the rise. We know that it takes up to 2 years for patients abusing methamphetamines to regulate and to regain their full cognitive abilities. So how do we expect patients to advocate for themselves while in treatment? One more time. Okay. While in treatment. Okay. So, Lucid Care. We're transforming the way disorders are treated and managed. What we do is we help patients develop positive daily habits that keep them in treatment, and they use these skills to apply throughout the recovery. We've developed this digital therapeutics platform that uses virtual reality to reduce anxiety and cravings within minutes. So how does it work? A trained VR facilitator comes into the rehab centers and runs VR sessions up to 10 minutes at a time. The facilitator shows experiences that are highly immersive, focusing on emotional regulation and enabling patients to focus, often for the first time in years. We measure a patient's state of mind through self-report assessments and tracking technology, and we're building this proprietary database so that in time we can more easily predict which patients are more at risk of dropping out and alert the clinicians so that they can provide them more personalized care. We currently sell directly to treatment centers and are already working with hundreds of patients. We are working with the largest drug Medi-Cal treatment centers in Los Angeles County, and we have 5 pilots. In these pilots, we've shown a 57% reduction in anxiety. Anxiety is one of the top reasons why patients drop out. We are making a difference. So I started Lucid Care because I wish I had VR to accelerate my behavioral change. So I built the right team to do this. My co-founder and CTO, Yahav, developed the first FDA-approved VR product for neurosurgeons. He also developed fighter jet simulations in VR for the Israeli Air Force. We're supported by an amazing team of advisors. Unfortunately, I guess there's some writing issues up on this. We're supported by amazing advisors from Stanford and opioid experts, as well as from the LA Department of Public Health. And we have an operations team based in LA. We plan on expanding beyond treatment centers to medical-assisted treatment, and we'll be working with methadone clinics and also physician offices that are looking for a tool to increase patient adherence. Ultimately, we're pioneering the way that behavioral health disorders should be treated. They should be treated as a chronic disease, and chronic diseases require patient engagement. At Lucid Care, we believe that the patient is part of the solution, and we teach them how to manage their chronic disease and help them lead fulfilled lives. So if you have any questions about our mission or would like to talk more about what we do, I'd be happy to answer any other questions. Thank you.
That was a phenomenal story. Rebecca, congratulations for starting that company and what you're doing. I mean, this is exactly the type of thing that we want to see. What's that? My mic's not on. How's that? Okay. Rebecca, you're amazing. Next up is Chris. So Chris Lento is CEO of FreeSpira and also known as Palo Alto Health Sciences. He's been around for a while. He comes from 25 years in the biopharma space, so that's quite different. And but he also spent quite a few years at Therapeutics, which is probably one of the pioneering digital therapeutic companies out there. We're going to see a digital solution for panic attacks, and it's really an alternative to a Xanax or a Valium. And Chris, I said I wish I heard about you before I got up on stage, but and take it away. Yeah, should be.
Well, good evening, everybody. How are you? Mark told me I had 5 minutes today.
That one working?
Is it working? How about this one? Let's try again. Mark told me I had 5 minutes to do the presentation. I practiced it twice this weekend. The first time I did it in 3 minutes, it was way too fast. The second time took me almost 45 minutes. So we're going to try for the third time here, and hopefully it's a charm. I'm Chris Lento. I'm actually the Chief Commercial Officer, not the Chief Executive Officer, but thank you. We are Palo Alto Health Sciences, ironically not located in Palo Alto, but Kirkland, Washington. Let's see here. There we go. Our product is FreeSpira. FreeSpira is an evidence-based, FDA-cleared We kind of call it a digital therapy because it includes both hardware and software, but it's cleared by the FDA as a Class 2 medical device. We're cleared to treat symptoms of panic, panic attacks, panic disorder, as well as PTSD, an indication we received this past summer. The product, in short, is cleared to treat patients 18 years or older. As you can see there is a tablet that connects via Bluetooth to a CO2 sensor. The key to this therapy and versus other breathing devices are that we actually measure CO2. The patients use this product at home twice a day, 2 17-minute sessions per day over a 4-week period. And they're actually getting biofeedback or feedback from the tablet, and they're shooting and targeting for target respiratory rates and target CO2 rates. Let's see, I think I'm going the wrong way. I'm going to skip forward because I realize I have a lot of slides. So the problem here is panic attacks, panic disorder. Depending on how you measure it, 19.1% of the US population has some form of anxiety disorder. We can put an estimate for panic and panic disorder is roughly 27 million people in the country suffer from this disorder, many of who are not being treated or not being treated adequately. So when providers, behavioral health specialists, primary care providers are looking to use our product, they're actually looking for patients both on the behavioral health side, mental health side, as well as the medical side. Disorders such as generalized anxiety disorder, phobias, and so forth have a high prevalence of panic attacks. They actually progress to an actual diagnosis of panic disorder, as well as medical conditions such as irritable bowel syndrome, cardiovascular disease, migraines, COPD. Those patients have a high prevalence of panic as well. So we go from 27 million up to 50 million if you want to include other patients with high prevalence of panic. They're typically treated with medication and counseling. Our product is not meant to displace medication or counseling, but as we heard earlier, medication is fraught with some problems. Medications are addictive, they're expensive, patients are not very compliant. On the counseling side, and I know we have some psychologists in the room, I appreciate and recognize all the great work you do, but counseling has its limits. It's very hard to deliver. Patients are not compliant with their face-to-face visits, and the system sometimes falls apart on the counseling side. We do, however, need these therapists, psychologists, psychiatrists to help us deliver this intervention. They're an integral part in delivering free spirit for patients. Just a little bit about panic, and if I ask people to raise their hands in the room, which I won't, I bet a good chunk of you do have experienced symptoms of panic or panic attacks. Patients think they're having a heart attack. They can't breathe. They feel something's wrong. And what they do in most cases is go to the doctor. Worse, they go to the ER, where they're treated for something other than panic, cleared, and their disorder is allowed to continue, driving costs upward.
The only difference is
With our particular product, and one of the inherent physiological effects of panic is patients suffer from chronic hyperventilation. This is caused by having too low of CO2 in the body. Time's up already? That was 5 minutes? Do you want me to just stop right there? Okay. So just 2 more points. We are evidence-based. We have run a series of clinical trials. The one on the left was actually done at Stanford, right down the road. The one on the right was our real-world trial done in multi-centers. The key here and where we're honed in on is fitting this product into physician workflow and having the patients engage with the therapy. On top of the phenomenal clinical response rates, and you can see there, 80–90% of the patients are panic-free or getting a statistically significant response. The patients engage with a 91–86% adherence rate. That means they're completing all 56 therapy sessions. 2 more slides. We have progressed to the point where Highmark's Vital program took us on a test drive. We graduated their program, and we do have full medical coverage as part of their medical policy for their 5.2 million members in West Virginia, Delaware, and the state of Pennsylvania. So we are fully commercial. 2 more slides. Our care model actually has two points. A provider authorizes the product, screens and authorizes the product for the patient. We ship it to their provider. Provider trains the patient. Patient goes home and uses the product for 4 weeks, and they're assigned a free spirit coach who's doing regular check-ins with them on a weekly basis. to increase adherence. And lastly, we do have a PTSD indication. We're in the process of scaling that. I spent today at the Palo Alto VA, where our product was tested, and from where we earned that clearance and up. We'll be hearing more about that in the near future. Thank you for the opportunity this evening.
Good job. Thanks, Chris. That was another just perfect example coming off the last panel of the types of sort of augmenting therapies that we're starting to see in market now that are really getting adoption. Let's see, so who gets to go next? Oh, Mainul. Mandel, come on up. Ellipsis Health is a really very, very cool company. It's actually funded by COSLA, and Alex did mention it in the past. And what basically, they want to make behavioral health a vital sign. And he's going to talk about sort of like a score, and he basically does it through speech capture. And it's incredibly innovative and exciting, and take it away.
Thank you, Mark. Can anyone hear me? No? Nope. All right. Switch it on. How about this? I hate my voice, but it's important. Well, thanks for being here. So, Mainul, Mondal, founder and CEO of Ellipsis. So I'm going to go through a few questions here, and we'll pause to think about what we're doing and why we're doing what we're doing. What is voice? Right? Think about this. It's been around for a long, long time. Voice is the original measure of well-being, right? That's how we have communicated with people. That's how we communicate with human beings, right? When you go home after work, you call your loved ones. If your grandma or your elderly friends are out in some other state, you want to check in how they're doing, right? That's happening in the developing countries, developed countries. But if you think about also places like Nairobi, Kenya, right, or a village in India, right? What's happening there? You have frontline workers who are sitting with the mothers or the patients, and they're chatting, they're connecting, right? Now, voice has a lot of rich information that's not being used the way it could be used in healthcare. Okay. Now, pause there for a second. Think about what has been happening in the last few years, right, in chronic conditions, thinking about how do you manage your type 2 diabetes, and so on and so forth, right? People have focused a whole lot on physical health, right? You have therapists, you have coaches, right? But if you really sort of dig deeper, right, the core problem is depression and anxiety, the state of mental being, right? And so for us, when we looked at it, it's okay, look, we want to build something that's going to be scalable, because there's nothing right now scalable to measure depression and anxiety. There's nothing. You have a paper-based form that you go through a list of 9 questions. You spend 10 to 15 minutes doing that, right? So we said, all right, what do we do? So we looked at voice. I said, you know what? You open up so much when you talk to your providers, when you talk to loved ones, right? So we need to find something that's measurable, that we can act on, and that can scale not just in the US or Silicon Valley, across the globe. The vital sign that we have now for physical health, we all have thermometers at home. We all have some sort of blood pressure cuff. There's nothing for behavioral health, right? So what we're creating here is the first behavioral health, clinically valid marker for depression and anxiety that you can use. And now the question is, how are we doing that? So it could be any conversation, right? We do take permission before we use it. Any conversation, whether it's a device agnostic, obviously. We take that conversation, and our machine learning algorithms look for semantic and acoustics, right? What you say and how you say. Because you could say, I'm doing well, right? And I would fool you. It's how you say. So we combine a bunch of things here. We need a few minutes of conversation, and the user knows when that conversation is being recorded. It's being streamed live, and it sort of gives out a vital sign. So it measures your depression and anxiety score in real time. Right. Now, if you were to sort of take, going back to sort of thinking about whether sort of use case around, and we'll get a little deeper in the use case soon, but thinking about, having a parent-child conversation, or, maternal health, suffering from depression and anxiety, right? So our goal is to sort of use it across many, many use cases. I will focus on 2 that we'll be talking about today, and happy to answer more as we, at 8:30. So So our first deployment, or first large-scale commercial deployment is going to be with Aetna and Apple. Aetna and Apple have been working secretly the last few years. They finally launched an app called Attain, right? Now, we're not in charge of the design, obviously. It's Apple, right? What we're in charge of is actually providing the voice engine. Right? So if you're an Aetna user, and if you're going to use this in fall or later this year, you're going to have an Ellipsis engine there. Right? It's a human-machine dialogue. They'll say, how are you doing? How's the week been? Right? And in real time, you'll get a score for the vital sign for depression and anxiety. Now, Apple has been, obviously, as always, very, very innovative. They're providing a lot of incentives to use the app. Right? So if you use the app, you accrue points, you get to buy an Apple Watch, and whatever. Right? If you go to their website, you'll find the release, you'll find a lot more information of how they're planning on engaging users. So our goal is to work with about 1 million users for the next 2 years. And if that is successful, scale across all of Aetna. The second one we'll talk about, this question came up, I think, during one of the sessions, being used for primary providers. I mean, if you look at PCPs, the frontline workers, the nurses, the case managers, they don't understand behavioral health. They don't understand depression and anxiety. What we're doing is we're augmenting, right? We believe in the human relationships. We believe they need to have providers. So what we are going to do is actually augment that. This is going to be a buddy, your advisor for behavioral health, right? So the way Intermountain is going to be using this is that during a primary care visit, as you're connecting with your provider, we get that speech, and then we let the provider PCP know what the level of depression and anxiety is, because based on that, there's standard care pathways. So what we end up doing is that we do the warm handoff, so that Intermountain providers can take actions. So where I started was that it is the original measure of well-being, and where we're going with this is that voice is going to be the future of our behavioral health. Thank you.
That was great. So we saw 3 great companies, and again, we're not voting for them. They're all winners, and so congratulations, guys. You're all total winners.
We'll begin with introductions for our panelists. And I will be from here. We'll begin with introductions for our panelists.
Hi, everyone. I'm David Lim, Chief Medical Officer at Quartet. This is sort of a homecoming for me because I actually used to live on this campus as an infectious disease fellow at UCSF. But I moved over to the healthcare tech sector, really committed to driving value-based healthcare initiatives, and I just love the mental health cause. I'm a depression survivor. I'm very open about it. But also as a clinician, I could see the ravages of the unmitigated and undiagnosed mental health conditions in my own patients with HIV, and the real struggle to actually navigate them into care and the disconnect between mental health and physical health. And so I really just love the mission of Quartet. I joined the company when there was actually no money. I was the first employee, and it's been an incredible journey, and I'd love to talk to you all about what we do.
Hi, I'm Brent Vaughn. I'm the co-founder and CEO of a company called Cognoa. Cognoa is a digital behavioral health company in pediatrics. So from Diane earlier says they wish people would do things in pediatrics. We are. It's a little hard. We're a little different from some of the other companies in the behavioral health space. Our products are software as a medical device that we are taking down the path to be FDA-approved devices that can be routinely prescribed, dispensed by physicians, and paid for as standard of care through third-party payers. We take a precision medicine approach to digital health, where we are able to develop digital medicines that diagnose and treat key conditions. Our first condition is pediatric autism. We're treating pediatric patients, diagnosing and treating them with autism spectrum disorder. Our two lead products are a digital diagnostic tool, which we'll use to fundamentally change the standard of care and lower the average age of diagnosis by more than 2 years so that children can have the opportunity to actually benefit from the prime developmental windows when their brains are developing quickly, and where all the published data has shown us that if you can intervene during those times, you can fundamentally change the lifelong trajectory of these kids. So paired with that, we have a complementary digital therapeutic that I can talk more about later. Both of our products have received breakthrough designation from the FDA, and we're getting ready to start our registrational trial for de novo submission.
Thanks, Brett. So hi everyone, my name is Ofer Leidner. I'm a co-founder and president of a company called Happify Health. We have been on the journey to create highly engaging digital therapeutics that focusing on mental health for the past 6 years. Coming to this world from slightly different angle, we thought that engagement is the first thing that needs to be solved, because if you can't solve engagement, it doesn't matter how good the intervention. People won't use it, it doesn't matter. We've gone through an interesting journey. We have a platform that developed that deliver evidence-based interventions and programs, over 60 different programs on the platform. Started the journey on the consumer side, optimized for engagement, and then started the journey on the enterprise side, self-insured employers, large health plans, and we have products across the continuum, working from prevention, mood disorders, and doing a lot of work on chronic conditions, and also stepping into FDA-cleared therapeutics with work that we do with some pharmaceutical companies.
Hi everyone, my name is Olam Matas. I'm the founder of BetterHelp. We're the world's largest online counseling platform, connecting people with a licensed therapist for counseling online over text, video, phone, or chat. We have a network of over 4,000 therapists. We provide therapy to over 500,000 people. And we do around 1.5 million sessions every month, whether it's messages or phone or text or video.
Hi, I'm Eva Borden, and I am with Cigna, responsible for our medical and behavioral solutions.
Hi, I'm Eva Borden, and I am with Cigna.
We're done. No, I'm kidding. So Ofer, let's start with you. We, out of everyone here, you're really digital-centric, somewhat gamified, and you have a gaming background. I want to ask you a question about, we mentioned this in the last panel, we've seen some consolidation with Enjoyable and M-Strength and Lantern. They were also digital-centric. They were also, evidence-based back. I'm sure you look at those. They're slightly different, I'm sure, but I'm sure you have to look at what others are doing in the space. What did you do right? And maybe you can talk to this as well, Eva, in terms of, where do some of these companies stumble? And maybe it's not where they stumbled. It's just that it was a lousy product, or it was they didn't have the right business model to get it out to commercialization.
Yeah, so I'm happy to start. So, I've listened to prior panelists and fascinated conversation. And I think that ultimately companies in this category fail for 3 reasons. One, their product doesn't scale, the engagement is not there, or they miscalculated the go-to-market strategy. Ultimately, these are the 3 reasons for which a lot of the products that have been consolidated lately, I think, failed. Good teams, good technologies, but models that aren't scaling, aren't engaging, or having to give the right go-to-market time. Our approach, as I mentioned, started with engagement. Prior to this company, I was the founder of a fairly large casual games company, and really kind of entertained and got people addicted to dopamine-enhancing loops. 60 million monthly uniques on our platform, and at that point I realized that if we can get people to do what we want from the devices through gaming, what if we dosage down that dopamine loops and marry it with evidence-based interventions to help people live better? There's no shortcuts. 3 years of optimization, 4 million users, before we even dare to start conversations with payers, with employers. And I think that ultimately we are holding the belief that software has a very important part of the equation. It's not going to be the only solution. I'm a big believer in cross-continuum, multi-tiered ecosystem of solutions. We want to be the software solution that does it the best. But really kind of endless optimization and engagement numbers that are there and clinical outcomes that are measured, published, peer-reviewed. It takes time. There's no shortcuts here.
When it comes to the scalability and commercialization, I think one of the challenges we face are, number one, a lack of understanding of all the stakeholders that are actually impacted, especially if you want to start working with a payer. All of the different people that a payer is responsible for working for. So it could be the provider, it could be the employer, it could be direct to consumer. And I think number two, the business model on how does the money actually flow. So the last panel, for example, you heard a lot about the fee for value versus fee for service type world. In all reality, a lot of the world is still very fee for service based. And the fee for value world is still emerging. And so when you think about what do reimbursements need to look like in a fee for value world, they're not always clear. And so those are some of the things when I see the stumbling, whereas some might say, oh, well, actually, the acquisition or however you want to describe it of those companies is a fail. I actually feel like they are better positioned as a result by it's ultimately that combination of bringing the mind and body together becomes really important. That I look at what they've done now and I go, now we're starting to really get into something super intriguing when you start combining.
Now we're starting to really get into something super intriguing when we start combining. You're addressing delighting the end user. So you're B2C, but you're going to B2B2C. But I almost feel important health is empowering the second P of the pie, which is the provider. How are you doing this? Because as a practicing physician in primary care, the tools, the time, and the education all three are kind of the missing piece for the provider. How are you addressing that?
Yeah, great question. Well, Quartet, I don't know if people know this, but the four components of Quartet are patients with mental health conditions, the PCP, the mental health provider, and the health insurance companies to get them to play in harmony, as some might say in our company. But really, I think of the answer to your question really in sort of two components is sort of a business side as well as a clinical side. Real quick on the business side, our customers, our paying customers are the health insurance companies, and our commitment to them is that we engage the comorbid population into a better mental health care path. And since the health plans pay for our fees, we can provide our technology and services at no cost to providers and to patients. And so on the clinical model, one thing to consider is that the cost, the vast majority of the American population is that PCPs will recognize mental health conditions. They will be very compelled to act on it, but their understanding of the mental health provider community around their clinics is very minimal, and they many times have to just start with an antidepressant or some psychotropic medication, and they tell that patient to please call the insurance company to find a mental health provider, and that's unfortunately what we would call standard of care. And so we're really trying to change that model we have. We deploy software that actually enables the PCP or the practice medical assistant or the nurse practitioner to send some just very basic information about who this patient is, their insurance type. We serve all insurance types in all our markets because we know provider adoption cannot really work if they have to distinguish one type of insurance patient versus another. And then we take that information, and sometimes if it's very clear what the need is for that patient, we can pass it to a mental health provider. That mental health provider has a very limited time window to review the patient, call that patient, and then make an appointment, essentially. And if they don't do that, we pass it quickly because speed to care is paramount to success in engaging in mental health. And so the burden is taken off the patient, and now really they connect all the information is transmitted now by this care team on our platform. We have social workers available as well to support that patient along any part of their journey, whether they're still pre-contemplative, contemplative, et cetera. And so really at the end of the day, what we're doing is really providing services and technology that really give the resources to the PCP and their staff, so they really have peace of mind about what's happening with patients.
So with the standard of care, you mentioned that the PCP basically sort of prescribes medication because they have a limited time limit. That's the standard of care. Because the other alternative is to find a therapist will take 2 months, 3 months down the road. Have you collapsed that time?
Yes, we have. I mean, I like broadly speaking, the prescribers, psychiatrists are definitely more of a challenge, but we're observing that we can get that appointment time down to like 2 weeks, roughly, for a prescriber across all markets. Therapists is even sooner, usually under 2 weeks. And that's in contrast to many of the sort of our benchmark is you will, depending on the market, is a couple months for psychiatrists. And so the way we're achieving this is sort of in multiple ways. We're making sure that patients that we send to psychiatrists aren't just like very, very mild depression or anxiety, but rather the more severe cases. We're also working with a lot of mid to large size mental health provider organizations that really view a partnership with Quartet as a way to expand business. And many of these prescribers actually love the fact that patients are tied to a PCP because they pick up on physical health findings many times, and a lot of times if there's an elevated glucose or an elevated creatinine, they're actually obligated to work that up, and they're not very equipped to do that, so they actually enjoy the
So Elan, it sounds like there's people falling through the cracks. I mean, 3 weeks is great, or 2 weeks is great. It's much better than the current model, but then they can go to BetterHelp and hopefully be directed immediately, right? So are you getting people falling through the cracks, or is there a way that you can also work with a payer who's clearly seeing a number of these people if they're administering like 70% of the prescriptions of their antidepressants?
So our average is actually 10 hours between the time that you sign up and the time that you start talking with the counselor. So our average is actually 10 hours. A huge improvement. We're not so much in the psychiatry and prescription space, so this is talk therapy, this is counseling. Still, it provides a completely different experience. And yes, there are so many people who fall between the cracks. They don't even go to the PCP, or the PCP does not necessarily recognize any mental health issue. But even when they do, and they tell the patient, you should talk to a therapist, the chance of that person actually going, finding, setting an appointment, and coming to that appointment therapist is extremely, extremely low. Nobody wants to do therapy. It's not fun to anyone. It's something that you can always find excuse to avoid. This is why, for example, we always have a huge lift in January and February because of New Year's resolution. Because this is like the anti-procrastination of the world. Things that you knew you need to do, like going to a gym or going to a therapist. Now you have an excuse or a reason to do. For most people, they would avoid unless it's easy, unless it's accessible and affordable. And we provide all these values, and you're talking with the same therapist you go into office. We're not trying to, there are many disruptors here. We're not trying to disrupt therapy. We're not trying to make a new model of CBT, self-help, gamification. All great. What we're trying to do is to take the same tried and true offering studied for 100 years or more and make it more accessible. Just solving this access problem, I think, is the most important thing to have improvement on how people get care.
And Eva, how would you, I mean, you're pretty rigorous when you have to bring a company into the fold. And so what does BetterHelp need to prove? Because right now you're B2C. And so what kind of statistics and measurements and outcomes does he have to bring to you to show that this is something you should make accessible to your network?
So I think there's a few different things, and I'm going to speak more generically. Just specifically, I don't know enough to be able to speak in an educated way. But I think some of the things that you're going to see just spectrum of how we look at bringing someone in. So part of it could be bringing them in as a true strategic partner, where we say, from an investment perspective, we're looking to truly advance, clear through to, gosh, we want to offer what you think you have a great solution. Maybe it's not a strategic partnership, but we still want to partner from an offering perspective. So a little bit earlier, I talked about the and pieces, that this would be something that would be an and to the other parts that are being offered. So things that we would look for really relate to it. We talked a little bit about behavioral health quality, really hard to measure. And so there's definitely intrigue on how do you measure that. A lot of it's going to be customer experience reliability. One of the things, like anytime you start working with a payer, becomes wildly important is privacy. And so if you can't overcome the hurdles when it comes to HIPAA, let alone 42 CFR Part 2, which will likely hit you if you're on behavioral, you're going to face a really hard time. And so for us, when we're looking at, if I think about our biggest challenge right now is access and availability. Definitely a massive challenge. And when it comes to the access, what kind of care do you want? What's the modality do I want to go after? Do I want text? Do I want face-to-face? Do I want video? And the adoption, even though I appreciated the stats we have earlier, to think about what those stats would have been 5 years ago till now, it wouldn't have looked, I venture, I don't know, I venture they would have looked dramatically different. So how will they continue to evolve? So that's kind of what I would think about is that spectrum of partnership. What are you bringing forward? How are you going to demonstrate quality in a world that's really, really hard to demonstrate quality? And then just essentially meeting the overall needs that we would have.
Just to follow on that, so you touched the topic of starting direct to consumer and going B2B, which is what both Happify and us are doing. So I think it's actually, in many ways, it's an ideal way to do it because you first want to prove that consumers want this product. It resonates to you, and that, once you prove that, then you can feel much more comfortable going to peers and say, there's something that people want, people use, and it helps people, and maybe this is something you want to offer your population. And we're both doing it, so we now, for example, work with United Healthcare for their student population. Every student covered by United get free BetterHelp service. And yes, they are looking not just for consumer feedback and reviews and people that love us on Yelp, but also for measurable results, but these start to become available. So when UCSF, the vice chair of psychology at UCSF was one of the researchers that actually published in January a very big study on BetterHelp and online counseling versus traditional in-office counseling. They focused on depression using PHQ-9, and what they saw is that the reduction of depression symptoms for patients that went through BetterHelp is either comparable or sometimes in some categories even better than in-office counseling. So it's definitely not easy, but there are the traditional ways to measure, and you can also do it online. And I think as these solutions become more and more available and more popular, there's also going to be more research.
And I think age plays some bias into this too, because people are more traditionally face-to-face in a population that is more used to face-to-face delivery of care. As we're getting closer to Gen Zs, they are actually interacting even with their friends sitting right next to them through their screen. And so I think it does become important that we're scaling these solutions for all generations in that way. And talking about generations, I want to talk to Brent about his Cogno as a solution, because I was intrigued because as a payer, a large employer, we do have several families that have kids on the spectrum, and it has direct impact on how present our employees are and their families are at work. It's the presenteeism, absenteeism, and impact on productivity is very, very valid ROI that we look into this, but how there is early intervention has impact on lifelong was very, very unique offering that I saw, that you start between a certain time frame and you can actually modify the brain synapses of this child, and that can have a trickle-down effect on mother not being depressed and father being more present at work. So I want to hear what your studies are and how are showing and how you're integrating it into the workflow of either employer, payer, provider.
Yeah, thanks a lot. So, in the talk about what are the different stakeholders, right? So when we think about stakeholders, one of the stakeholders that we think about from the very beginning is the payer. And when we started thinking about how do we build a product that has a high degree of engagement, because we're firm believers, I think probably like most everyone in the room, that higher engagement ultimately drives higher compliance, which can drive better outcomes in the behavioral health space, right? And so when we started doing this, we tried to figure out what are payers that are easy for us to start engaging with and start building our learnings, while in parallel we are executing our randomized clinical trials to take to the FDA. And so what we did is we developed, as we were developing our algorithms, some of our early AI algorithms to do the diagnosis were showed that they could clinically outperform the screening tools that are being used in primary care physician offices. So the American Academy of Pediatrics says every single child should be screened for autism developmental delays at all their well-child visits. It almost never happens, right? The tools take about half an hour to use. You have about 7 minutes if you're lucky in your well-child visit with your pediatrician. And so what happens is the kids just aren't getting the care they need, and they're missing out on these windows. And so when we sat down and started to think about how could we start getting experience engaging to show that we could actually move with better outcomes, we started working with some payers. And the payers that we started to work with were self-funded employers. We were able to sit down and we actually learned a lot by starting with SAP. SAP is the company that started the Autism at Work program, and so they're committed to having 1% of their workforce on the autism spectrum. And because of their understanding of this, when we came and talked to them about if you are having parents and your employees more informed about the world of autism, what's going to happen is parents are going to start be looking for more and more answers as they have kids, right? A higher awareness. And ultimately awareness drives increased diagnostic rates. So we started working with employers and we started to understand what does it take for us to start engaging your employees, because we could show them clearly that a parent who has a pediatrician that looks at their child and puts them onto a waiting list to get diagnosed by a specialist, because all autism diagnoses are done by specialists. The average wait in the US right now is 13 months to have anyone look at your kid. So imagine a parent at work for over a year wondering what's going on with their child. When you talk to the pediatricians, the overutilization of primary care explodes during this time. Every time something happens to the kid, the first thing you do is you go into the pediatrician, because the only question you really have, will this bump me up the list, right? How can I get someone to look at diagnose my kid sooner? And so we started working with some people like SAP who understood this, and we started implementing the product. And we learned a few things, right? We learned that 2% of kids roughly are diagnosed with autism. About 1 out of 9 kids are diagnosed with ADHD. But even at 2%, you're kind of looking for haystack needles, right? It's 1 out of 40 kids. And so what we learned pretty quickly, and SAP really helped us figure this out, was if you're going to find haystack needles, you build a machine that processes haystacks. So we stopped doing things like screen your kids for autism, right? Because if you want to scare a young parent, that's a good opening line, right? What we figured out how to do was engage every parent. So all of our messaging changed. This is what every parent does, right? Every parent should know that their child is on track. And I was looking at our curves from our first clinical studies, and about 20% of the kids were being flagged as having elevated risk, because obviously people come to us when they have a little concern. And I was staring at it, and there's a guy, Paul Willard, who used to be at Practice Fusion and at Atlassian, who's super smart about product. And I'm staring at it, and I'm like, you know what, Paul, about 15 to 20% of this is successful. And he said, no, Brent, you're wrong. Your number one selling product is peace of mind for parents whose kids are on track, and 85% of your kids are successful. And once we figured that out, we started engaging with payers. Our engagement is quite high over at SAP. They've renewed to do this the second year and are rolling it out more broadly. And what they helped us understand is that the behavioral health condition that we can treat at a screening level is peace of mind for every parent, and that translates directly into decreased absenteeism, decreased presenteeism, a lower cost of potential turnover, because SAP is pretty close to 50-50 male-female in their employee base, so it doesn't matter which parent stays home with the kid. And so what we learned was that stakeholder had a very different view of where value was than when we sit down and talk to people like the Blues and United, who those stakeholders, once again, are interested in capturing value, but they have some different levers that they look at.
I thank you for that. I don't want to keep asking you questions, so have everybody talk as well. But this question is to you, and hopefully others can answer it as well. So you talked about, I think you clearly explain how valuable this is for a parent to want to have their child diagnosed with, screened for autism. It takes 13 months. So if you go to your pediatrician today, so when you go to a pediatrician, what is your product, and how are you helping the pediatrician screen their child?
Yeah, so the first product is a screening tool that's been clinically validated. Pediatricians or parents can actually engage with it directly. They can complete the assessment before they present into the physician office, and they can share the screening result with the physician. So it will identify for the parent if their child has elevated risk for delay and show them how to communicate that to their pediatrician.
So you're going through SAP, so the employers are at the SAP, the health benefits folks, are pushing this out to the employees to self-diagnose themselves and then bring it to the pediatrician.
Exactly, to screen and engage. They provide Cognoa to all of their employees in the same way they provide Livongo to all of their employees. And so we can help provide peace of mind to parents. We can find the children that are at risk and bring them to the attention of their existing trusted family physician. Our second product, which is the one that's going through the FDA path, will take that kid with elevated risk and allow the physician to diagnose the digital diagnostic as an app, and the child will be able to, or the parent will be able to complete the information with the child, come back once again to their pediatrician just the next week, and be able to get a diagnosis and start treatment.
I guess that works really well as long as SAP is definitely out there helping to make this success, creating awareness for it. So Oprah, do you feel that you are getting that support from some of the distribution partners that you have? I mean, are they making it very important for people to have this screening or take your test, or just see how not resilient they are?
Well, I think the key in kind of understanding distribution is understanding what is the second order driver. Why would people be interested in your tool? And it's very different between employers, health plans, and pharmaceutical companies. All right, so ultimately the employers, they all care about mental health, but they want productivity, right? They want the workforce to perform. They want the workforce to show up to work, be at their best, and essentially deliver what they're paid for. On the health plan, it's about quality of care and cost reduction. These folks are tasked to manage that. For pharmaceutical companies, it's a different story. It's adherence, it's patient engagement, and many other things. I think that one of the things that we've done in every channel, and we really do think that there's a silver lining of having a multi-channel strategy. So yes, we do work with large health plans, and our journey from consumers was we actually got the call from Cigna. Hey, we saw your product, and on the consumer side, we think it could be helpful for our users, for our members. Went on a journey, and just that it's not a short journey. It's 30 months from first conversation to scaling contract. So be prepared. You measure the growing efficiencies. So second pair would be shorter, but that's tough. And it's rigorous analysis. But then once you basically encourage people to kind of use the tool, and if they're working, if they're self-engaging. One of the things I keep going back to engagement. In mental behavioral health, we do talk about 20% of the population walking around with diagnosable conditions. We do see across all the traditional paths of care, 2, 3, 4, 5% engagement. That's not enough. What happens with the rest of the population that is walking around undiagnosed? And I can tell you that 20% is an underreported number. With every population that we're working with, Silicon Valley, we're working with 2 out of the 5 large tech companies on a global basis. 45% of the population is walking around with diagnosable mental health conditions. That's better reflecting what I think is happening. But then kind of approach is engage as many as you can into a process that is destigmatized, work with the distribution channels, help them understand how to market for their populations, engage them in, screen them, understand what they can use, care for those who you can care through software, most scalable solution. But if people show up solutions that actually, or conditions that need higher touch intervention, right away, care manager, behavioral health care manager, a better health-like solution. So we're really kind of thinking about it as an ecosystem of solutions that are connected, sharing data subject to HIPAA, and that's to us the solution that would solve this problem at scale. It won't be a single solution. That's the point of view that we have.
I just want to say that we have 10 minutes left. We're extending it a little bit, so if anyone has questions, please raise your hand or stand up so we can at least get all the questions in.
I want to just quickly qualify that the employers not just care about the absenteeism and presenteeism. We care for and care about the employee and the dependents. And I want to say that care for, because the self-insured employers are paying out of pocket for the care. And then care about is truly them being the best version of themselves at work.
I 100% agree with you, but I would just say that the reason why behavioral health, mental health is going into the C-suites, beyond the kind of benefit managers, beyond the health strategy folks, is because people really understand that the culture that is driving this stress, anxiety, and depression is damaging the bottom line. That's what I kind of refer to. Obviously, employers care for the employees, but what bothers the CEO is my workforce performing? Am I doing my best to help my workforce perform?
I agree, and so the bottom line is not just the presenteeism and absenteeism, and I think Signa will also agree, Eva would agree that if there's mental health issue, it affects the healthcare dollars, and that affects the bottom line for the company itself. And healthcare is a strategy, it's a core strategy for a CFO of any large organization.
Absolutely. And I think one of the things as I was listening to everyone talk that I find so unique about, just even as everybody here was sharing, when I think about what we're trying to do, and whether it's an employer, whether it's an insurance company that is funding it themselves, meaning that they're actually taking on the risk, is how do you knit all of these things together? So for example, you're talking about autism, hugely important, but then we're also talking about resilience, hugely important. How do you connect providers together? Super important. How do you provide quick access to care? Think about the 3 companies we heard of at the beginning, and that's just a small sample of all of the things that you have to tee up for a particular consumer at any point in time, and figure out what are the handful of things you need at any given point in time. And so it's when I think about some of the, and I can imagine being a founder, or as you work on some of these, it can feel really frustrating that I'm trying, I've got this great solution and I have a really good idea. Why isn't anyone listening to me? And I think part of the challenge is really understanding the fact that it's trying to knit together all of these pieces in a meaningful way, and in a way that consumers will actually choose to say, yes, I want to engage.
Yeah, I think, one of the things, and there was a question earlier in one of the earlier panels about, as you see the consolidation and roll up a lot of these companies, what kind of happened, right? I started in a pretty old school healthcare company. I mean, my first job was with Lilly, right? But one of the things everyone used to talk about all the time is that improvements in healthcare do 2 things. They improve outcomes and they lower costs, right? And the cost that we might lower for Hewlett-Packard, right, who has an average time with a given employee as a covered life, 10 years-ish?
Yeah,
18 years. I'm guessing the average time that you have to worry about covered line at Cigna is a little less than 18 years in terms of how often they change their plan, right? And so when we think about how we're doing costs, right, how we're going to lower costs while improving those outcomes, the cost that we lower for HP will have slightly different levers in it than when we're talking to Cigna or when we're talking to United. And when we sat down and whiteboarded out our solution for some of the people in the large payers, some of the things that we thought were interesting features to our product were huge value drivers for them, because they have a different event horizon for looking at these ROIs, and then they multiply these numbers by not 50,000 or 100,000 employees, they multiply it by tens of millions of covered lives.
So how do you integrate into that? You said it's all about improving outcomes and lowering cost, but it's not about, there's improving outcomes, but it's sort of how you improve outcomes. And the reason why we are so reliant on prescription medication is because it does produce the outcomes and it allows the physician to bill. So how do we start thinking about changing a business model in that context so you can allow physician to integrate other possibly better solutions that produce maybe even better outcomes, but you're not giving that a chance. So how do we start thinking about how to change the incentive structure and the business models?
I mean, I think that, in my preamble, we kind of talked about our approach, right? We look at the world similar to the way, say, Therapeutics or Achille or Click does. And we think that if you're going to say you're better, then at some point you should do an evidence-based outcome study to show that you're actually better than standard of care. And I think that there's areas where the endpoints suck, right? And that can be kind of a problem where you're going against endpoints that you don't really believe in. But I think one of the differences between a lot of the Health 1.0 companies, what we're seeing at the beginning, there was things where everyone was more in the wellness space. They like to talk about engagements, but they seem to assiduously avoid doing the outcome studies. And I think if you're really going to try to improve outcomes in healthcare, you need to be able to do the studies that show you can hit the endpoints. And there's really two types of technologies out there. Those who are figuring out how to prove the outcomes to show that they can change them, and those who are assiduously avoiding doing those studies because deep down inside they don't believe it works.
Dave, do you know that? You kept nodding your head to some extent.
No, I think what the way I'm observing, like this, basically the way I'm interpreting the question is like, how do we move from fee-for-service into value-based care, right? And especially, I think what I'm noticing in the healthcare sector is that mental health is obviously becoming a huge lever to drive value. And today it's mostly in the health plan world, but more and more I'm seeing provider systems recognize this, and they're starting to progress into integrated care or developing deep partnerships with mental health provider organizations, and then seeking out technologies to connect the two different worlds. And I think what I'm seeing is that the health plans now want to transition into a value-based fee structure, a reimbursement with health systems, and they're offering things like Quartet as like, here's a tool, we're going to fund this, we want to see, obviously it's Quartet's responsibility to drive an ROI, but as we transition to the value-based world, we will want to have you take on the responsibility of adopting and incorporating technologies like Quartet, and you will pay for that fee. And so I think that world is coming, and we're preparing for this because, and we need to adapt to the different ways provider systems are already beginning to innovate themselves around this. And so it'll be exciting to see how this all fits together.
You have a question? Oh,
yeah. Have you met with provider systems or with consumers or the employers to buy into the technologies that you're now offering in some ways? There's that first gap of getting it accepted clinically, and then there's the second gap of actually having it leveraged in practice. So have you guys gotten to the stage where your technologies are used in your employee offices, and how are you kind of facilitating that as companies?
So our technology is actually in the provider office, and it's a very good product market fit because I hate to say it, but the bar is set so low around mental health because again it's if you equate, like if I were your physician and I diagnosed you with diabetes and I told you to go find yourself an endocrinologist and thought my job was done, I would get sued for that, right? And so, but somehow right now mental health, that is what's going on. It's like you go find yourself a mental health provider, and this is not my responsibility. And that's the last time I checked, the mind is connected to the body. And so so the adoption for our technology, at least in terms of getting resources and getting a support staff that might be remote, but it's better than what's going on today, is very welcome. And then as we tack on things like teletherapy or CCBT or motivational interviewing as additional elements of that, the toolkit that the PCP now has, it's a good fit.
One of the things that I'll say from an employer perspective is, so we're made up of thousands of employers' lives is essentially what ends up coming in. I will tell you, for the most part, you're going to have some employers that are very advanced in talking about mind-body right now and talking about behavioral health. Those who talk about it are truly advanced, because for most of them, they're just getting into the space. A lot of them are coming up and saying, hey, I got millennials for the most part, and they want to talk about this thing, and I don't know what to do. Give me some digital tool that I can throw at them and hope that they're going to be okay. I mean, just to say, if you've got 250 lives and that's what you're dealing with, like, that's the conversation. And so It's how do we help create the conversation in a more meaningful way to make sure that the things that we put out there and are available are being used in the right way. But it's hard. That even that if you have it, it kind of goes back to if you build it, they will come. Yeah, well, they don't always come, and so how do you continue to get it out in front of them? So there's a lot of conversation to be had there.
On how difficult or easy, what are the differences in the insurance companies that you've had to work with and the challenges?
It's definitely easier to work with consumers. Because and consumers are also the best critics of your product. If it resonates, if it's good for them, they will pay for the product and continue to pay for the product. And that's the only thing that matters in a consumer relationship. When we talk with employers or health plans, it's kind of two layers. It's the layer for consumers that we already know. There's also the gatekeepers from the middle that need to be convinced, that what we're saying that we're helping consumers is actually true. It's getting easier as 5 years in and hundreds of thousands of people with measurable results. It's getting easier, but also that we can save to them. And I think one of the issues with mental health in general is that it's very difficult to prove ROI with mental health. So we're part of Teladoc. Teladoc is a lot of general medical, and I'm kind of jealous how easy the work is, because you had someone doing it online visit with a doctor instead of going to urgent care. Very easy to prove why it's saving tons of money. With mental health, since most people actually don't get any care, it's not about this type of care or that type of care, then you go into things like absenteeism or productivity or other things that were mentioned here that obviously intuitively we all recognize there is some value there. It's just very difficult to put in Excel. Like, how do you quantify absenteeism? How do you quantify lack of productivity? The other issue that I think we're seeing there is that there's kind of a conflict of stakeholders, because productivity helps to VP of production and or someone that's in charge of business results, where these costs usually need to come from health costs. So the incentive of the person that needs to reduce the health cost is not absenteeism that helps someone else in the organization. So you can need to convince it through someone who doesn't really own the budget.
Yeah, and I think if you look at the 3 Ps, which is the payer, provider, and the patient market, so what BetterHelp talked about, from the payer perspective, especially from an employer perspective, I think the strategy becomes, how do you enter that market? We look at uniform experience for our population and what is the pain point. So if we do have mental health and behavioral health as a big issue, we generally want to lean onto our insurers that are insuring our employees' lives and dependents' lives. But we also sometimes feel that because of the fragmentation of different insurance companies, we might as well take the solution out and give it to all employees for a uniform experience. So like Happify, we could pick Happify. If this is a pain point for us, we can use Happify as a standalone solution, not embedded in a Cigna model, and then give it out to all people, whether they're going to Kaiser, they're going to Cigna, they're going to United Healthcare. So we look at our need. We look at the cost, of course, and then we also look at how much of this end user experience we want to enhance by having this service offering, whether embedded in a solution or standalone.
I think also mental health and counseling specifically is a little bit different, because to doctors, most people go through their insurance. And when we started BetterHelp, we thought that without insurance it would never work. And then we started talking with counselors and looked at their invoices. And what we found is that actually most people who go to counseling, go to see a therapist, don't do this through their insurance, even when they actually have insurance coverage, because of stigma, because it's very difficult, because they need to be diagnosed. So this is a space where people there's huge access problem, but also people feel more comfortable to pay for themselves and not necessarily through their payer.
There's nothing wrong with that. I mean, we should be much more responsible about the budget and the cost of things we pay for. So I like the direct-to-consumer model. No
I mean-
offense.
I mean,
The
what-
insurance companies are the middlemen, but it's much more transparency for.
I mean, one concern if you're starting a company in this space in the direct consumer side is that there are areas, in working with therapists, perhaps certainly cosmetics. There's a couple areas where patients will pay a premium to go to what they see as a premium branded direct to consumer solution. But in most of healthcare in the U.S., if your insurance, if it's not a qualified expense that your insurance will cover, it is treated as an inferior good, right? And they avoid it, and your price point will be lower. When we first started, and I had VCs explain to me that parents don't care about developmental screening, they'll never do it. They will never share private information just to find out if their kid has autism. I had one VC said, you will never get 6,000 parents to sign up and do this. So we stood up a website to prove him wrong. When we hit 250,000, he said, oh, I always knew you guys would kill it on acquisition. But when we were doing DTC studies and we put, for a free product, would you like to be able to use your insurance, your CPC drops almost in half. For free, right? And if you just have the check here, if you would like to be able to use your insurance or if you have insurance, the CPC drops dramatically because they think that means that someone in an insurance company at Cigna has vetted this solution.
We have to wrap it up. Yes. We're about almost 15 minutes.
So I'll be nice, promise. So first one is, there is an organization which I was part of that's now reformulated called the Validation Institute. And the Validation Institute is designed to stop what happened in wellness, which is people claiming bullshit about how great the thing was. And if you guys are not involved with the Validation Institute, Vida Jorgensen just rebought it and just reformulated it, worth talking about, so please take a look. Because that will prove that your stuff works as opposed to not working, which is, one of you said that together. Second, it's not a problem because all your employees there for 18 years, they're all aging into Medicare, so you can get out of the business completely, so it's great.
We take care of pre-Medicare, pre-65 retirees, so we also assume risk for that.
All right. My final point was the serious question is, okay, so most of what we discussed, I don't want to belittle any of this, most of what you discussed is kind of relatively healthy people stuff. Now I know autism is a big deal and what have you, but it doesn't fit in the ground of sort of the chronic illness that we discussed earlier, which involves, I have COPD, I have diabetes, I also have depression and anxiety possibly as a consequence. So maybe you are there. What we're seeing in the market is those companies, you mentioned Lento, we also mentioned My Strength, both of them being sucked up by bigger, richer chronic disease management companies. And you're kind of going down that path, I'm sure. You're thinking about this even at Cigna. So do you believe that for sick people, people who have multiple conditions who cost all the money, that you will end up as independent companies, or are you going to be making bigger alliances or acquisitions, or are you going to be part of something that's looking at the whole of the human?
Yeah, so a big part of what Quartet does is we actually have a data analytics team, and with our paying plan customers, we actually ingest claims data, and we do a number of things in terms of really actively searching for mental health care gaps, and this is very much focused on that comorbid population. So it's absolutely looking at patterns of utilizations as well as clear mental health care gaps, and we can observe where there are opportunities to close these gaps. And so so for one instance, if you have a patient with emphysema and anxiety, and they're always going to the emergency room to get a shortness of breath workup, but they're never getting admitted, they're never getting changes in medications, and it's pretty clear that this is always anxiety. We can see that same pattern of behavior with just a patient who has just emphysema, and then we can work, since we have a great partnership with our PCPs, we can work with the PCPs to say, hey, these comorbid patients, you don't know when they're going to the ER, and we have this information for you, and there's an opportunity here to engage that patient in a discussion, destigmatized discussion about mental health. You can talk about Quartet, and we can be a resource to engage that patient, and that is truly the method we drive ROI to our health plans.
I think we're the different one here, so I'll keep it short. I mean, for us, we look like a specialty pharma company. We have a technology platform where we're developing diagnostics and therapeutics for multiple behavioral health indications that leverage the same platform. Our product will actually be ordered and dispensed and billed through specialty pharmacy, just like the products that Genentech originally did, who I think paid for this building. And so for us, we get on that path. You think about what happens to specialty pharma, they either go public or they ultimately get acquired by someone in the biopharma space.
I get to. Yeah, two quick responses. So first of all, I think that, I mean, we're doing a lot of work on the comorbidity with chronic conditions, with populations that we work through. Payers, I do think that ultimately the strategy of prescribed therapeutics is the one that actually fits really, really well for chronic condition population, because ultimately the specialist would feel much more comfortable prescribing something than kind of going into disease management protocols that are just more cumbersome. So I agree with you. For chronic condition, it's going to be prescribed.
I think part of your question, also a question from the first panel, was about the less privileged population. And I agree with you. Like, I have friends who work for Google. They can have 40 counseling sessions free, covered, on site. They're good. People with who are less fortunate need to pay sometimes $600, $800, or $1,000 monthly to see a therapist. And that's completely not in their reach. If it wasn't their reach, it's probably they would have employed by Google or any other company. And I think this is where technology that break access barriers and lower the cost, because it takes away all the overhead that comes with that, like BetterHelp, where you can pay almost a fraction of what you'd pay in traditional in-office counseling, can help those population. And we see that a lot of people who come to online counseling, there are many reasons to that, but a lot of them, that's the only counseling that they can afford, because they don't work for companies that have all these privileges.
Eva gets the last word.
Oh, okay. Yeah.
Wrap it up.
No, so I think as we refocus back on why does behavioral health matter so much, it actually has to go back to that connection between the mind and the body. So when you talk about the consolidation, what's the end goal? I obviously am not speaking for these gentlemen, so I can't speak in the same way, but I will tell you from what we care about, it's all about how does it all fit together across that entire person and the entire person's needs. Are they showing up as the best versions of themselves at work? Are we helping them be productive? Are we helping the employers control their medical costs? Are we helping the providers actually be able to get people to the right types of care that they need? No one would ever stand for someone, say a PCP, saying, I'm not going to screen you for breast cancer because I don't know an oncologist. And so our tolerance for what that needs to look like from a behavioral health standpoint needs to completely go away. So that's my closing remark.